loves to educate and support, encourage you as you start your ER journey. She was once a biochemist, right? Okay, and then she decided that nursing was calling her. So she went into trauma nursing. So that finds her here in the ER, and she's also dabbling with entrepreneurship. It's going to be so great learning from her. Jess, why don't you just tell us about yourself and what you are doing currently, and where your passion is in the ER?
Well, currently, as you and I were just talking offline, I'm trying to deal with moving all of this nursing education online, as we know, because of the pandemic going on right now. I am a nurse educator. I teach at a couple of nursing schools, and I teach full-time at a medical school, which is awesome. I'm a nurse, teach people how to be doctors, as it should be. And I do work per diem in a level 2 trauma center. Can never leave the ER. I absolutely love it. And as you mentioned with entrepreneurship, it's total happenstance. It's kind of crazy to even think that I have a business. I think of it more as a hobby.
Mm-hmm.
But I think it's just kind of how nurses are. We're always exploring, kind of always chasing more education and ways that we can make a difference. And so that's kind of where I'm at right now. I've got a very full plate, but I think it's because I like so many things in nursing that I just can't pick one to do.
I love it. So when did you realize you had a passion for your current line of work, whether that be ER as a whole or entrepreneurship, wherever you want to put that?
It's kind of funny. Backing up to when I was actually an undergrad as biochemist, my senior year, I TA'd a chem lab for the nursing students. And they frustrated the heck out of me. And at that time in my life, I absolutely despised nurses and despised teaching. And it was funny, it's like 20 years ago. And I just remember thinking, oh my gosh, all these nurses, all they are is like ditzy cheerleaders, and they cheat off of each other, and, they're all stupid. Nobody can understand anything. Of course, I was, thought a lot of myself back then. But anyway, became a chemist and all of that stuff. And I decided to stay at home at some point in my life with kids. And honestly, as crazy it sounds, and I hope my dog's very far away, but I'm sure you can still hear her.
You're fine.
But anyhow, I watched a lot of Trauma, Life in the ER show. And it's crazy to think I'm a nurse because I watched too much TV when I was a stay-at-home mom. But I really thought this is the coolest job ever. And just to get out of the house, because I was going crazy, I started to volunteer at a hospital down the street. And I'm like, nurses just have the coolest gig. You could work a handful of hours a week. You can work a whole bunch of hours a week. This is great for somebody that doesn't want to work full time and be away from the house because you got kids. And so it's kind of a combination of watching these shows and seeing how cool ER is, and just being in the hospital setting and thinking it's really cool. And when I did work as a chemist, I did work for a medical company, so I've always loved pharmacology and biochemistry and all of that kind of stuff. But then I ended up in a master's entry in a nursing program. I had a bachelor's degree in biochemistry. I had all my prereqs. Pretty sweet.
Yeah.
Kind of slid right into that program. And but then, the ER is such an incredible team environment, and we always have students in there. So, and I just loved showing people what, how to do things. And I was precepting at one point once I gained experience, and one of the students, or one of the nurses I was precepting, was like, gosh, you should teach. And I just remember thinking, no, I don't have the patience. I can't teach anybody anything. And she's like, but you're so phenomenal. I love, having you as a preceptor. So I'm like, I'll look into it. And I started teaching clinicals at a local community college. And I was like, I really love this. And so it's so funny if I could go back to the 25-year-old me and be like, guess what? When you actually decide to grow up and get over yourself, you're going to be a nurse and an educator. The two things you think you absolutely can't stand right now. So
that's phenomenal.
Yeah.
And that's true for all of us, right? If you could go back and tell your 21, 22-year-old self, hey, it's always good to remember those messages. Let's see. Star says she's a new nurse, so thank you for joining us, new ED nurse. And then Gil says online's an absolute pain and scary, man. You're right. but we have these teachers like Jessica who are dedicated to helping you continue your education despite the craziness. So let's just be thankful for them in this time. So you already talked about what you did prior. How did you feel like your background in biochemistry really prepared you for being a nurse?
Well, in all honesty, I don't know that it necessarily prepared me to practice as a nurse, but it definitely helped in all of my pharmacology and pathophysiology classes, plus my interest in it. If you could take all the chemistry classes that you want, I don't know that it necessarily prepares you for nursing school science unless you're actually interested in it. So I definitely take that into consideration now with my students. Those are hard classes if that's not your thing. So most definitely it helped me get through those classes. It definitely did not help me with nursing theory, which I thought was the most painful class. And other people that, have their undergrad or something in English or whatever, liked those classes more. But I think that nursing, any other degree or anything that you've done before a nursing program, I don't know necessarily prepares you to be a nurse. I mean, it's one of those things that you really, it's more of what kind of a team player you are, how empathetic you are. And, those matter way more than, any type of schooling.
Sure. Did you start in the ER as a new grad?
Yep. And I did. It was pretty crazy.
Yeah, especially that long ago, because when we first started nursing, it was still maybe that was when the shift first started, where they were kind of like, okay, we'll put new grads in the ER. Okay, we'll put new grads in the ICU. But that was kind of a new, like, let's trial this, or at least it was for us. What about you?
Well, I think it was like, oh, we're desperate enough.
Okay.
We need a warm body with a license attached to it, right?
All right. So do you feel like, and I know your answer, but I want you to elaborate, do you feel like it's okay for new grads to pursue their love of ER nursing straight out of the gate?
I absolutely do think that that's appropriate. And I think that it's beneficial. It's so crazy, these specialties, and not just the ER, whether it's the ICU or pediatrics or, surgery. They're so highly specialized that, it just drives me crazy when people are like, oh, you need to go on a Medsurg floor and get experience first. If you go onto a Medsurg floor and you enjoy it, then you should stay on a Medsurg floor.
Mm-hmm.
But my concern is if you are passionate about the ER, or again, any specialty, and you just go onto the Medsurg floor with this idea that you have to do this, like, some huge Medsurg clinical or something that you need beforehand, you're going to not like nursing and you're going to be miserable because it's not your thing. It's kind of like, oh, you should go visit China to get experience before, going on vacation in Italy. Like, it's totally two different things. So I just think it's crazy. I think new grads have a hard time no matter what unit they go on to.
Yeah. And Medsurg really is a specialty all on its own.
Yeah.
And I feel like you need to treat it as such. It doesn't matter whether you're starting in the peds unit. And, orientation of new grads is so expensive. And these experienced nurses pour themselves into you. Don't feel like you have to go waste a year of their time and then go skip off to something else. Like, go where you're interested is my own personal perspective.
Well, I think it's actually kind of an insult in a way to the Medsurg nurses. Like, oh, you're so basic. I'm just going to come up there and get a little bit of experience, and then I'm going to go do the hard stuff.
Yeah. I agree.
I wouldn't last a day on a Medsurg unit. I mean, their depth of knowledge on so many things far surpasses mine. I won't let anybody die, but God forbid if I know anything about chronic illness and how to take care of it.
Yeah, and the number of patients that those nurses juggle is phenomenal.
Yeah. High executive functioning skills on that unit for sure.
Yeah, I definitely couldn't do it. All right, so let's talk to those new grads who are interested in going straight to the ED. What's most likely their training process going to be like?
It's hard to say what's most likely. All of these hospitals are completely different. You have, these beautiful ivory tower hospitals, great, like here in Chicago, like we have Northwestern downtown. I mean, it's just this phenomenal healthcare system, and they've got a solid system of education and nurse residency programs, and but those are very small numbers, that they're accepting in versus the nurses that are graduating and wanting to come in. So likely to get into one of those is, not likely. So the vast majority of the rest of the hospital systems that don't have a residency program to really bring you on board, where they have didactic courses and some time on the unit, and you for 6 months to a year, it's just continuing education before you ever go on your own. The majority of the hospitals don't have that.
Yeah.
And then what's outside of that, right? It's just this whole spectrum of, when I started, it was sink or swim. It was like, here's your preceptor, but here's your patient, so she's your resource. Not like she's going to teach you. And it was, wait a minute. So you have some programs where you're really going to have to you have some thick skin, cry on the way home if you have to because you're overwhelmed. Find resources outside of the hospital if you have to. The whole reason I started emergency nursing or bust, right? Like, build a community somewhere, get these resources, have a mentor, and a lot of it, kind of like nursing school, you're going to have to go outside to get some resources to really help you be successful. And then you'll have something in the middle where you will have a little bit of an onboarding. Some hospitals will give you, 6 weeks. Some hospitals will give you 3 months. It's really dependent. And this is the one thing that is really important when students are interviewing.
Yes.
Because students are just so desperate. Oh, I want to get in the ER, and it's a level 2 trauma center. Like, somehow that's better than a level 2 or a level 3. And it's really for those, I mean, it definitely is a cool place to be, but when you're a new grad, anywhere is going to be fine. Don't even think about what level trauma it is. But when you're interviewing, don't just be so desperate to get a job anywhere because you want to get, in any ER. Really, really, really be picky about what their onboarding is, because ER can be super overwhelming if you don't have people supporting you and educating you. So, I make it sound so dire or whatever. It's awesome. I work in an ER where we just half, if not more, of the nurses I work with started there as new grads, and they've been there maybe 2 years, so I work with a lot of still new nurses, but we love students and we love our new nurses. So, whatever we can do to educate them. So definitely find an environment like that.
Good advice. So what does a typical day look like? And when patients come in, how are they getting assigned and divvied up?
Well, what we do is triage patients when they come in. There's an emergency severity index is what we use here, at least in the United States, to triage patients anywhere from a 1 to a 5. 1, being you're basically dead and you're going to get all of the resources in the ER because we're actively trying to save your life doing CPR. And they're almost not even assigned. Like, when they come in, it's just like a quick look at who's available. Everybody goes into the room anyway. And it's more about reassigning that nurse's patients to somebody else, whoever ends up just jumping in and grabbing them. But then you have fast track patients, which are on the other end, which are like your 4s and 5s. And most ERs, bigger ones, have separate areas for the more critical patients, and then for, fast track patients, the less critical ones. And so they're kind of initially divvied up, if they walk into those 2 separate areas. And then as far as patient ratios, people talk about nurse-patient ratios all the time, and what are they in the ER? Well, if I've got somebody that's an ESI of a 1, I can guarantee you that's my only patient. If I have a patient that's an ESI of 2, which is, can be anywhere from somebody actively having a heart attack to, somebody that's short of breath, I might have 2 of those patients. Maybe sometimes even 3, depending on how busy it is. So kind of as you go down, the least severe they are, the more of them you can have. There'll be people in fast track that have 10 patients. And it's like, oh my gosh, I have 10 patients in an ER. Well, yeah, because this one's got a runny nose and this one's got a hangnail and, things like that. And then your charge nurse is the one that's really ultimately making those decisions and kind of watching what nurses have how many patients and what level of acuity. And then again, what they can handle. Is this a trauma nurse taking a trauma patient? And so it's a very, very complex but very well choreographed process.
It sounds like it's really dynamic, and it's probably not the same in every institution.
It's pretty similar. I think you can go into any ER and they're going to have the same triage system. The thing with triage, it is a little bit subjective, and some ERs are a little bit more stringent. You know, if I come in and I complain of chest pain, they're going to make me an ESI of 1, even though I have no cardiac history. You walked into my ER, we do an EKG and then make you a 3. So there's kind of that wiggle room, the numbers. But the process, I mean, the charge nurse runs the place. They run the nurses, they run the doctors, they run the whole place. And so you really hope you have a good one that knows what they're doing.
Yeah,
but
for sure.
They're all run by the charge nurse making all of those decisions. So
awesome. So what would you say your top 3 challenges are in the ER?
You know, honestly, for me personally, at this point in my career, are the people. You know, I do work with a great team where I'm at. That's why I'm there. If I didn't, I wouldn't. Mm-hmm. But, you know, the challenges can be, team interactions and, you know, knowing who's got your back or who doesn't have your back, knowing who's your resources. Everybody that's got experience as an ER nurse will say, well, they'll walk in and they'll be like, oh no, it's the B team today. Oh, awesome, it's the A team. Like, you know how your day is going to go because the strong people, the weak people, that's not so nice to say, but you kind of have an idea about it. So kind of functioning, getting used to who you're working with, and if you've got the C team on that day, I mean, that's what's challenging, is to know that it's all on you for the most part. But I would have to say, for the average, younger, less experienced nurse, the challenges are really keeping up. Really being able to know how to do a thorough focus assessment, to know how to do a differential diagnosis. They don't teach those in medical school, how to do that. And that's really a medical way of thinking like a physician and anticipating what the physician's going to order. And, not drowning in your charting, taught to chart so many things, and in the ER it's really knowing what needs to be charted, what doesn't need to be charted. Those are the challenges I see. Like I said, a lot of the nurses in my ER are younger, and those are the challenges that I see that they have, slowing them down, stressing them out.
And I think I've learned a lot in my process here in TribeRN, and something that I learned, and it made me chuckle a lot, because as a PICU nurse, you want all the details. Well, when was their last BM? And, and the ER nurse is like, I don't know, and I don't care. Like, what's it to you? This patient is tubed and breathing now, and let's move him on, Right. And so it just made me laugh, because I was totally that nurse on the phone receiving a report from you being like, okay, well, when was their last moment? And you're like, who cares? So it made me laugh, because as a nursing student, you're taught all of these things, and then you walk into your unit and they're like, no.
Well, and see, that's the thing, coming back to one of our questions earlier about, get experience on a different unit, like a Medsurg unit or a telemetry unit or something like that. That stuff needs to be untrained.
Yeah.
You'll have these nurses come on, and it's just like all the other nurses are like, oh my God, you are an experienced nurse. You've been a nurse for 10 years. Why are you so slow? Well, because you've been a Medsurg nurse for 10 years, and you're in there talking to the patient, like you're admitting them. You're doing this full-on admission, and it's just like, no, you could have been through like 10 patients by now. And so, it's a whole different beast. So sometimes it's a detriment to go somewhere else first.
That makes a lot of sense. It does. So would you say, which, I mean, we can all anticipate that this is a high stress environment, but how do you decompress after a stressful shift? And are there resources to you available as an ER team?
Stress is such a funny word, because in a way it's a good thing. You should have anxiety sometimes when somebody's coming in and they're short of breath, and is that stressful? You have to be able to move fast. And it's stressful, I think, on any unit. We have nursing shortages and all of that stuff. So I think it's really personality dependent, because I could have the busiest day in the ER with the highest acuity patients. We have babies die. We have moms dropped to the floor, screaming and crying, begging you to bring this kid back. I mean, that's hard stuff to deal with. And again, yeah, ER, it's stressful. But people that say that, they don't have the passion for it, I think, because to me, it's not stressful. It's hard work. Kind of like, I like to run. I'll go for a run, and people are like, isn't that stressful? Well, yeah, I'm sweating and I'm exhausted, but I'm going to go for a run tomorrow. And when I go home, I'm like, I feel so good about that run, even though I'm so tired. And that's kind of like how a really stressful ER day is you go home and you're like, God, we had just a kick-ass team today. That was a hard day. People dying and patients out busting at the seams and all of that. But as stressful as it is in the moment, when you go home, to decompress, you just sit there and think through the day and you're just like, we totally rocked it. That was awesome. Of course, there's the days that you didn't rock it and it wasn't awesome. And
Sure.
How do I decompress? I like red wine, but talking, really just having a good friend, especially one that's either a nurse or a paramedic,
Sure.
somebody that gets it, and to just talk it through. So again, I'm always going to fall back and have a network, have a mentor, have a tribe, right?
Yeah, for sure. And do you guys do an mentorship program? So you have a preceptor, but do your new nurses have a mentor as well, or do you have that program in place?
No, not within the hospital. They're not assigned to a mentor.
Okay.
Not where I work now, and honestly, never where I've worked before. And I actually think it's good to have a mentor that's outside of the facility that you work at. One, to give you perspective, think outside the box. I mean, my professional mentor is the dean of the pharmacy school at the local university. So he's a pharmacist. And he doesn't do what I do, but he's in healthcare and he's out, I like to think outside the box. So when I say get a mentor, definitely get a mentor within healthcare, but it doesn't have to be an ER nurse. It doesn't have to be a nurse. And I really think that it should be somewhat detached from, you have to have somewhat of a separation of your mindset to get perspective and have somebody, really be able to guide you, to grow you. You can't really grow if you're all in the same box.
Agree. So what do you think, if you were going to pick just a few characteristics that make a nurse successful in the ER, what would they be?
You have to be a good team player. You have to leave your ego at the door. There's no competition. Don't even think of coming in and worrying about what somebody's going to think of you. You have to be willing to be like, yeah, I was wrong. No, I don't know how to do this. You just lay it out on the line, what you don't know, what makes you uncomfortable, what scares you, when you need help. Don't try and be better than anybody else. Don't try and think you're going to be smarter than anybody else. I mean, walk in there, I don't want to say, I was about to say walk in there naked. Not physically, but exposed, vulnerable, and be like, this is me, this is how it is. And then when you get feedback, and you will get some feedback, you'll have nurses or other staff, some physicians here or there, that'll make you feel stupid, and this will be on any unit, not just the ER. That'll say stuff, and then, you'll want to put your guard up, and you'll want to not ask questions then because they made you feel stupid, and you just can't. So you need the characteristic of being able to be vulnerable, and then just thick skin, being able to be like, what, I'm not going to take this personally. Then you'll realize, there's people that really aren't the nice ones. Of course, we hear about bullying in nursing all the time. It's not just you. I mean, that person's unhappy for some reason, and they're unhappy no matter who they're talking to. So learn not to take things personally. And then just always stay up to date on new things. Be willing to learn because it just changes constantly. And you have to be smart. You have to know what you're doing, because I'll tell you, and again, I think this can apply outside of the ER, which is really important in the ER because time is life and death. You'll work with some providers, whether they're physician assistants or, I haven't really worked with nurse practitioners in the ER, unfortunately. So, PAs and physicians, sometimes they're just outright wrong, or they're jaded, or, I can't even tell you how many times that I've caught errors or thought, maybe we shouldn't be doing this. So being able to disagree with a physician and being able to say, this makes me uncomfortable. I don't want to do this. But you have to have a good reason to. I don't want to do this because I think it's dumb. Well, what makes it dumb? Well, I don't know. It just sounds dumb. And you have to know, like, have your resources, have your evidence base, but that's pretty much.
Okay, good. Do you have a favorite tip or trick that you think is useful in the ER?
Obviously we do a lot of procedures in the ER. So a tip or trick, it's kind of hard to explain things without like showing tips and tricks and stuff like that.
Sure.
But one of the things, especially for new grads and new people wanting to go into the ER, everybody wants to be able to be a, expert at inserting IVs. So to new grads anyway, or to students that are practicing, always wear gloves, obviously. I started out wearing 2 pairs of gloves when I was learning as a new grad, because I was in a patient population where like everybody had like hepatitis and HIV and all of these things. So I was so freaked out. And trust what you feel, not what you see. So as far as a tip or trick for IVs, which you have to do all the time in the ER, definitely be safe with the gloves, especially now, right? Like PPE is the talk of the town. But don't be one of those people that rip the tip off of the finger of your glove. Why even put one on? I don't get it. So when you're new, challenge yourself to do things the right way, and even a harder way. You put on 2 pairs of gloves. I'm telling you, you will get to the point where you could feel a vein 5 inches away from the tip of your finger through all of this adipose tissue. You'll be able to feel that with 2 sets of gloves on, and then when you only have one on, all of a sudden your vision is like crystal clear, and you'll become better at it. But so it's kind of a tip or trick for that, which is probably the most common procedure that you'll do in the ER.
All right, cool. And then what do you love most about your specialty?
The people, the team, including the patients. It's just, I'm such a people person. I like to be around people. And in the ER, everything's about working as a team. I mean, you really don't do a whole heck of a lot of anything independently. Whether you're the one helping other people or you need help from other people. And even, when I'm in the emergency department, I have an idea of everything that's going on. I don't just have my patients and here's my schedule for the day and the meds I'm going to give and just focusing on that. You're constantly watching everybody. And, if you think for a minute, hey, everything's going easy, I'm going to sit down and take a break. You look around and you're like, is somebody else running around like a chicken with their head chopped off? What can I do for you? And you'll get that. If you walked in the ER I work in, you will see before anybody sits down, they'll just look and be like, do you need anything? Like, they're not going to sit down until everybody's okay. And
awesome.
Right. I mean, it's cool. It's just a great feeling.
Yeah, and that's good teamwork. So any of you, even if you're not in the ER, no matter what your specialty is, be looking out for your team because it's contagious.
Yeah.
When they see that you're willing to give an extra, moment of your time for them, they'll reciprocate. So you wanted to title this "Go Big or Go Home." Why don't you tell us why that's significant to the ER?
Well, it's kind of a joke for one. It's a saying that's kind of a joke in the ER because we say that when we're talking about either, you have a trauma patient that comes in and you're talking about what size IV to put in this person, it's going to be go big or go home. You can't really go wrong. You need to either slam fluids or blood into this patient as fast as possible. So you go big or go home. During, cardiac arrest, you're doing CPR. It's like, oh, well, what should we set the defibrillator at? The highest one. Like, they're not going to get any more dead, right? So it's like go big or go home. It's not just going to scale up. We're not, converting anybody. They're dead and we're trying to bring them back. So so you just hear the term a lot when in certain situations in the ER where it's like somebody asks a question and it's just like, duh, go big or go home. Like, so but I just like the term because I think it's kind of like go all out, or or don't play at all. Like, if you're going to be on the team, you're going to be all in, or you're going to be all out. There's no middle ground.
Absolutely. So most nurses have a side hustle or a second job. You have one. Why don't you tell us about it?
Well, I currently have like 5.
Okay.
But my favorite one is the one I made up myself last fall. I started a business. It's actually, a legitimate business. It's a limited liability corporation. It's called Emergency Nursing or Bust. It totally happened on accident. Never in my life have I ever wanted to be an entrepreneur. I still don't know that I want to be an entrepreneur. It's a lot of work. You wouldn't know anything about it, right? But I was at Emergency Nursing Association conference last year, and I absolutely love the ENA. But one thing that I noticed is very predominantly supportive of emergency nurses. Duh, right? It should be. Phenomenal education and all of that, but, is very scant, scarce, I guess, as far as education for those wanting to come into emergency nursing. And I just know so many of my students want to be emergency nurses. So I was just like, oh, and I sent a text to one of my students and I said, hey, if I created an emergency nursing course, do you think anybody would want to come? And she's like, oh yeah, of course. And less than 24 hours later, she sent me a link to a Google Doc with 47 students signed up for this class that I didn't create yet, nor did I commit to creating it. It was just a question. And it just kind of blew up. So I created a Facebook group, and I thought, oh, maybe it's just because these are my students. All I do is talk about emergency nursing, so they're biased. They get fed, emergency nursing.
Watching them.
Right. And I'm like, so maybe I've just created a little cult, and it's just in my little bubble that this is interesting. So I created the Emergency Nursing or Bust Facebook group, and, it like blew up. And I think there's well over 2,000, some are emergency nursing nurses already, but they want to be mentors, which we need them in there. Yeah. But people just dying for this education, and I wish I could keep up with it. I'd love to have a whole curriculum on there for them now, and so I'm working on it. Trying to figure it out to get all of this education. I've got one little rinky-dink course up there that's really just was more of a trial to kind of throw it up there, a triage course. And it's not this super stellar course. I shouldn't be down talking my work, right? I should be promoting it. But there's, I have as my only product, if you will. But, I'm trying to get better at technology so it gets a little bit more fun and interactive. But in my spare time, like I said, I teach for, 3 different universities. I still work in the emergency department. I actually got pulled into an expert witness role. A friend of mine, an ER nurse, became a legal nurse consultant quite a while ago. I hadn't talked to her for years, and she called me out of nowhere and asked me if I wanted to consult on this. And I was like, oh, tell me about it. And it's, it's a really sad case, obviously. There's no good outcomes when things go to court. But super intriguing, and, just makes you really, really feel valuable. It's kind of scary how much lawyers don't know about medicine. But then it makes you realize, well, this is why they have legal nurse consultants, I guess. So yeah, I didn't expect that to happen, and it's really cool and exciting. I wouldn't want to do it as a full-time job. I think my eyes would fall out of my head looking through all of this documentation. I don't even, as nurses, we don't like to document that much as it is. Imagine now having to read everybody else's.
Right. And then, but it's probably providing a lot of clarity for you in what you absolutely have to make sure you're teaching your students to document.
Yep.
Yeah, for sure. Yep. Okay, so what are you looking forward to most in your career as you go forward?
I have this kind of pie in the sky dream of really making a huge impact in academic nursing and getting emergency nursing as a core course. You have Medsurg, and you have psych, and you have community nursing, and OB, and peds, and you really start to look at the data, the surveys that are put out by NCSBN, the National the boards of nursing that create NCLEX and stuff like that. And you realize so many students are going into ER and critical care, and we don't have those as our staple in these programs. And so I just feel like, you know, I kind of want to make a revolution and have this be a core thing. I mean, you have, outside of the fact that you have all these people interested in it, you have the World Health Organization who's been saying for a decade that we need to be in our academic nursing program, not just teaching our nurses after the fact, emergency nursing and disaster preparedness. And look what's going on in the world right now. Like, we need people prepared to take this whole pandemic on. And how are you trained to do that? Through emergency nursing and disaster preparedness. Like, you know, it was a big thing that blew up, and everybody was talking about it after 9/11 so long ago, and, you know, it was the hot topic, and then it kind of faded off. And I don't know, I think, you know, we can't really squeeze it into our curriculum any more than it already, how big it is. So something's got to go. So I don't know, boot out nursing theory, right? No.
And nursing research.
Yeah, right. Save that for the graduate education.
All right. That's awesome. No, I absolutely love that. And I can't wait to see what you do with that. We have exceeded our time of 30 minutes, but I do want to just throw it out there for anybody who's still listening. If you're interested in disaster preparedness, look up FEMA. We have a Q&A on it in the unit section. It's a good resource with lots of guidance on how to get that disaster prepared training, and your organization will pay you to do it. All right. So Jessica, thank you for tuning in with us, and we will chat again soon.
All right. Take care.
See ya.